Right. Good afternoon, everyone. My name is Hein van den Wildenberg. I'll be chairing today's Primary Care Commissioning Committee. James Bullion has sent his apologies. It's a meeting in public and will be recorded and will be available on YouTube later on. We received apologies from James Bullion, Tricia Dorsey, Hilary Byrne. I do want to clarify we are quoted. We have Stephen Coors here and Chris Turner, who is deputizing for Tricia Dorsey. We have a pretty full agenda, so I'll try and keep us to time today. Declarations of interest are in the pack today. We received a helpful comment that probably we need to look at consistency of some information that is held in the conflicts of interest register. So we will be doing that in terms of whether people are at practice or not. Rosemary, you had a hand up.
Thanks, Hein. I just wanted to add that I have started in a role as Senior Primary Care Resilience Manager with the ICB. So that needs to be noted, please.
That will be done. Thank you, Rosemary.
Thanks.
Just want to check with anyone in view of today's agenda. Is there a specific interest that anyone wants to highlight? No, thank you. That takes us to the minutes of the meeting. I'll take them in their entirety and want to ask if anybody has a comment as to the accuracy of the minutes. Assume that's a legacy hand, Rosemary.
Apologies, it is time.
Yeah. No comments. Many thanks, Sarah, for preparing these. Which takes us to the actions, which are on page 15 of the pack. I see a number of them are closed. There are two that are due in February, so I'll not cover those. And then there's an action 128 to provide information on benchmarking, which has been included in the notes. So I think we can put it as completed. So that's a pretty swift discussion there. Mark, you have your hand up.
Thank you, Hein. And just to say, I know it's for February, but just to update for action 126 around the comms in support of primary care, just to update members. So some of the activity we've been doing since the last meeting is around being quite focused on debunking some of the myths around primary care. We've been sharing a lot of the appointment data, demonstrating the work that's being done in primary care. We've worked with the EDP and our comms team have been doing a lot of work with the EDP and Look East, and actually there were 3 articles in the last month that have gone out trying to support and get them some of that messaging across, and still really pushing the social media campaign around being kind and respectful of colleagues. So we'll keep doing that, but I just wanted to update members that work is very much ongoing as it was discussed at the last meeting. Thanks, Hein.
Thanks, Mark. Very helpful. If there's no further comment on actions, we have item 5, the forward planner for the next 2 meetings. Anything you want to highlight there, Sadie?
Nothing to add, Hein. Okay.
Thanks. So that's for noting. And then we come to item 6, the risk register. I'll hand over to you, Sadie, whether you want to point out any specific updates there. Thanks.
Thank you. So we have only one red risk now on the register, which you'll see highlighted there, the resilience of general practice. So if I just talk about that one first, you will see from the update that we have been in discussion with the local medical committee prior to Christmas around what support we can provide to general practice around enabling them to clinically prioritise patients. We are a system in that remains very challenged in terms of urgent and emergency care, and obviously January is an exceptionally busy month normally anyway for general practice. So we have written out to two practices on that to provide them with some assurance over how we will support them in being able to clinically prioritise patients where that might impact them in other areas. We've also very recently had approval for some funding, which works out at about £150,000 for each of our 5 localities, specifically to support winter resilience in general practice. And discussions, of course, continue with the local medical committee around what more we can do. And Mark has highlighted some of that actually in terms of some of the comms work that we're doing. So it remains very, very challenged in general practice, just as it does everywhere else. In terms of 2 other risks, which I just wanted to highlight, PC10 is, sorry, do you want me to pause just there? Because I know we had a hand
Mel,
up.
you want to come in on that specific risk?
Yeah, I just wanted to highlight, we discussed at last month's meeting, following comments that the LMC had made in an email to the PCCC on the 8th of December, asking for interface issues to remain recorded as a significant risk to general practice and therefore the NHS system locally. I have to say we're disappointed to note that that specific risk has not been referenced anywhere within this month's PCCC papers again. And it's something that we keep reiterating, that practices keep reiterating. This is a major cause of risk factors to general practice. We've worked with the ICB for a number of months now and have pulled together an action plan that's actually been sent to the secondary care providers to mitigate these risks, or at least acknowledge that they exist. So we've got a question as to why that's not actually being reflected in any PCCC papers, because we don't think it gives a clear picture or a true picture of the issues in general practice.
So at the last, I think, what month are we now? January. So it would have been in November. There was an agreement to close the risk because of the infrastructure that had been put in place to support the work around the secondary and primary and secondary care interface.
Yeah, I appreciate that, Sadie, and that's what we questioned on the 8th of December. And you'll note in last month's minutes that the chair agreed to keep it back on the agenda.
Sorry, I wasn't party to that. I think my suggestion.
Yes, sorry, it's in the PCCC minutes of last month's that it was to go back on the agenda.
My suggestion would be that we include a reference to it within PC 14.
Yeah, that's what we're asking for. Yeah, so rather than update a separate one, because it's not separate. And I will just say that's notwithstanding all the work that we know the ICB is doing, but I think this is so significant that it needs to be reflected. Otherwise, general practice is not aware that the ICB is taking this as a serious issue.
Yeah, I think the team will take it on board. I agree that the specific risk was agreed to close, but we'll make sure it's referenced going forward as part of that other risk.
Thank you.
Thanks, Mel.
I'll pick that up. Thank you. And I'll share an updated suggested version with you, Mel.
Thanks.
2 more risks, if I may just highlight them to members. PC10, which is gabapentinoids, and Michael will refer to this as well in his report. As you'll see from the risk summary, the trends are quite positive for us as a system now, and Michael is expecting that we may be able to reduce the risk score on this in the next, assuming that everything continues in the next one. And at that point, if it does come down to the target level, then we would be recommending a closure, which is in line with its individual target date of the end of March.
Right, Michael, you want to come in?
It was just on the summary scores. I think it went from 9 to 12, and that should be 9 all the way through, I think. So just need to get that altered. But yeah, if it remains below top quartile, then that would be my suggestion, that we retire that one for the time being and just monitor it in the paper. But we'll wait for next time, I think, is what Sadie's saying. Yeah.
Thank you.
Okay.
I'll check the summary. Yeah, I can see there's a mistake in that. I apologise. And then SMI, severe mental illness health checks. There is a paper on that today. I just wanted to point out that this one has a target date at the end of March 2023, and it's unlikely that we're going to hit that target date in reducing the score to the level that we set. So I would imagine that at the next meeting where we discuss risks in March, we will be recommending that risk is extended for a further year. But we will also pick that up in the next couple of reports that we provide separately.
Okay.
Thank you.
Any further questions for Sadie on the risk register? No, many thanks, Sadie. That takes us to item 7. I believe Shepard will talk to the learning disability health check updates.
Hi, thank you, Hein. It's a brief paper, really, just to demonstrate the progress that has been made from last month. So we've made 6% increase in activity from last month. Compared to the same period last year, we are 11% above, which is really positive. And overall, at the end of November, we are at 44%. And just to say, it's November, we are expecting that in December we would have hit over 50%. So we are waiting for that data to come through, which is a good place to be in if we are looking at our national target and also our local ambition. I think it's fair to say we are on track as planned. In terms of the actions that we are taking to make sure that we remain on track, is we are continuing with our delivery meetings with our locality colleagues, and also talking to practices that seems to be struggling. We are reaching out to find out if there's anything that we can do to support those practices. We are also looking at additional funding, if that becomes available, to try and really maximize those individuals that we have not been successful to reach out. And hopefully with that, we'll be able to support some of the challenges that the system has in terms of discharges and admissions to urgent and emergency care. The information continues to flow to the PCNs and also to practices, so that we have a single conversation based on the data that is available to us. And we'll continue to report on the progress that we are making month on month. The final point I would make is around, obviously, the indications around risks. We've received feedback from practices around slowing down in December, obviously partly to do with some of the weather conditions that we have experienced, and also the rain pause that is being experienced. For example, yesterday, one practice had booked about 7 people, and there was no attendance. which is really appalling. And we were reflecting on what we could have done differently with that, potentially phone calls, follow up when there are changes in the conditions to encourage people all to do things differently. And also the festive period, we've seen obviously a reduction expectedly that later part of December and early part of January. We are focusing now on the year-end position. We are going to push a bit more, obviously without breaking the system, and making sure that we reach out to as many people and families to make this count this year. Thank you.
Thanks, Shepard. A very helpful update. Other questions or comments for Shepard? Mark?
Thank you, and thank you, Shepard, for the report. Just out of curiosity, it's good to see that we're making good progress on this and the variation across Norfolk and Waveney. Could I just ask, Shepard, how do we compare to regionally and nationally on this? Because that's also quite a useful metric for us. Have you got those figures? It'd just be useful to know and understand where we are. Thanks.
Thank you. And for the first time, Mark, I've not included those details, and you've asked that question. I can confirm that for the last several months, it's always been there. But it's good that you've brought it up. We are leading, not that we are competitive, but we are leading in the region, and it's well recognized that we have done more in the system. Our register is one of the biggest. We've seen more people than any other ICB in the region, and possibly in the country, I would say.
Well done. That's good news. Thanks, Shepard.
Thanks. Stephen?
Thanks. Thanks, Shepard. Really useful report. You mentioned the next steps about an additional bid for funding. Can I just clarify, is that a bid for funding for this financial year to continue the push with this work, or is that something kind of for the longer term?
We're looking for this year. Just to say, the national target is, I don't like talking about targets, but I think they are there to help us to focus. So the national target is 75%. That is what is expected of the ICBs. But we've set out a local ambition beyond that. And the additional funding is there to help us to meet both those targets and beyond, to reach out to more people. So it's for this year.
Thanks. Any other questions or comments for Shepard? James?
Yes, thank you very much, and thanks, Shepard. Your comment, and I did read it in the paper, I'm sure, that we've got a lot more people registered with severe learning difficulties in our region, our area. $64 question, how and why, and you know, are our measurements such that we are measuring it differently, or?
I think rightly so. I think our register did not start like this. Our register has improved over time, and there is that consistent pattern, I think, across the country that the registers are growing. And some parts of the country had not had the focus and the rigor that we probably have had in the east of England. I think it's fair to say Norfolk in particular has got a higher proportion of people with learning disabilities compared to some of the parts, and partly to do with the fact that we had lots of hospitals that were looking after this population. So there's something about our area in terms of the proportion of people with a learning disability. And it's fair to say, I think we have seen an increased focus. You will be probably aware that we had a national peer review to just help us to drive the improvements in our area. And because of that increased attention, I think we are in a strong position in terms of our register compared to other parts of the system, I would say. But I'm sure, I don't think we are any different in terms of saying we are recording things too differently, but I think we are just putting more attention to what we are doing than other areas.
Thank you.
Robert. And Mel?
Yeah, I agree with what Shepard has said there. I think it's also possibly pertinent that Norfolk was one of the original pilot sites for the LD learning disabilities health check, right from the off many years ago. So I think practices are quite well versed in identifying and working with partners to identify specific patient cohorts. And I think it goes without saying that general practice has done really well in identifying these patients and delivering this service with the support more recently of the ICB.
Thanks, Mel. Very helpful historical context. Any further questions or comments? No, many thanks, Shepard, for the note and good questions and comments made. We'll turn to item 8, the SMI health check. I saw Julian has joined. So over to you, Julian.
Thank you very much. Good afternoon, everyone. Just like to talk you through the SMI update for this month. We are still awaiting the Q3 performance data to be released by NHSE. So we are still utilizing the Q2 to reflect on where we are and what we would like to achieve. Acknowledging that the paper has been read, I just wanted to focus on the progress plans update and then move on to some of the benchmarking performance data, just to talk you through it. So the first one, in terms of progress plans updates, we unfortunately experienced 2 main delays for our pilots that we were hoping to launch to provide additional capacity for these SMI health checks in Norwich and in the West locality specifically. The ambition was to provide additional activity to mimic some of the learning learned within the LD health checks. For Norwich, there were issues with recruiting the extra clinical staff that needed to provide the additional capacity for these SMI health checks. I'm meeting with the locality reps next week to actually bottom out where we are and when we can relaunch and refocus this activity increase. So that's number one. The second delay was in the West locality in Swaffham and Downham PCN specifically. This is around ICS staff, ICB staff that have unfortunately left their posts and resigned. So the localities carry 2 vacancies that are unfortunately leading to delays in launching our proof of concept. For both, we are not requesting any additional monies. This is about reprioritization of staff within those 2 main areas to focus purely on SMI health checks as a proof of concept to show that actually if we consolidate our resource, we can make a marked improvement and hopefully lead to a nomination of a business case or additional monies to actually make this more substantive. So if we have unfortunately experienced delays, but I'm hoping over the next few weeks, those can be ironed out and we can submit a new plan to provide additional capacity in those 2 main areas. I'll move on to my benchmarking performance data. This was a request that was brought about for the last PCCC. I had to rush to use some of my local intelligence to build forward the picture that you can see embedded within the paper. One of the glaring things I will point out that this shows all of the ICB locations split apart. It's a bit misleading when you look at that because you could say actually Norfolk and Waveney, we've got the largest register. But that's not true. I have received some more detailed in-depth analysis from NHS England last week, which, if the committee permits, I would like to elaborate at the next time because it consolidates the ICS systems into main groups. So it actually shows a much fairer representation of where we are. I think one of the main things that I would like to draw out is focusing on a similar register size. BLMK is probably one of our main competitors. And I think I mentioned in the paper that when you look at the number of checks versus the overall size, BLMK carried out 315 more checks than us, but have 710 patients less on their register. So I think there's a lot of work we could do to actually consolidate those numbers and do a bit more of a deep dive into where we could exploit the gains made But for next time, if I am very happy to take that as an action to consolidate those ICS systems to give a clear benchmarking position of where we in Norfolk and Waveney sit in the ICS. The other things that we wanted to acknowledge was we're going through this, our local trajectory that we split about in quarters. And one of the main things is one of the risks was around the winter and the risk to activity as due to the pressure felt in primary care. We've just had a meeting today with some of our locality colleagues who have brought some concerns over from primary care and the GP practices to say, you know, they are experiencing a higher workload. Our trajectory has allowed for this, but I think we are hoping that it will follow a similar historical trend to say Q4. We'll see a catch up for some of the activity lost during the winter months. So I think the only other thing for me in terms of update was I was also asked to bring back some of the learning from the overall health check meeting that I attend. This does not just look at SMI, it looks at LD, diabetes, etc. We meet every once a month, and today's meeting was actually really good. So in time for next month's PCCC, I will do a very quick paragraph on the main terms of reference, what we hope to achieve an outcome. The headline snap from that meeting is effectively, we would like to empower our patients, show them the wide availability of checks that they can access in primary care, remove some of the barriers to why they are not getting there. And it's one of the main headlines for me from today's meeting is we are looking to launch a roadshow in each of the main localities in Norfolk and Waveney, showing patients the collaboration between communities. So we've already got buy-in from Tesco, Weight Watchers, Slimming World, etc., to show them the multiple of health checks available, help them to coordinate and make this a bit more community feel. This is some of the learning we've learned from London. So I'll stop for my update there, and I'm very happy to take any questions.
Many thanks, Julian. Also the prompt on some of the updates you'll provide in the next occasion. Any questions or comments for Julian? Bill?
Thank you, Hein. I think this is again, it's very interesting to see, and thank you very much for the benchmarking data, because I think that really helps. And I think, you know, we get a sense of what we're working with. So I'm really pleased to see that included. And I just wanted to pick up when you were talking about your meeting with the health checks generally. So, for example, on diabetes and other long-term conditions. I'm really pleased to hear about this roadshow. And I do like the idea of the suite of options being open to patients, because I think if our long-term ambition is more prevention and also people being more involved in taking care of themselves, which I think is an ambition for us all, then if we give them information through health checks, then they can make the necessary adjustments to their lives before they get to an acute setting in order to do these things. So you know, I really support this. I think this is going to be a key piece of work going forwards for part of the ICB strategy and looking at the 5-year plan about. So you know, I don't see the health checks work being a project that we'll finish and put in a drawer. I see this as something that will grow and hopefully be rolled out across more cohorts of people, so that we come to a point where actually we are interacting with most of the population when they come to primary care, that they will be giving information on their condition for them to make some lifestyle changes and things. So I do support this. You know, I think the roadshows is interesting, and I hear you say, well, you know, there's some interesting stuff from the London boroughs. I'd be really keen to hear more about that, because if this work has already been achieved elsewhere, it would be much easier for us to build on the existing models than having to invent something from scratch. So maybe we could have, you know, I know these are coming back every month, and I was just thinking we get the quarterly data. So maybe once a quarter we have a bigger focus on this particular one, but maybe we could utilize the in-between months updates on health checks around the general strategy of health checks across primary care. I don't know what you think, Hein, but it's just an idea. Thank you
I
very much.
like that idea personally, Bill. Maybe we can frame it as an action point and ask the team to give it some thought how to best shape that in the forward planner. Thanks, Bill. James.
Yes, thank you very much. And I was just coming in to fully support the case Julian's made and Bill's comments very much. I think it's my experience is that one can get health check through from the primary care doctor's surgery. I mean, is this something that has been considered to be taken as a separate preventative item rather than I use my words with difficulty clogging up the surgeries. I can remember a few years ago at Suffolk County Council here at Endeavour House, we had health checks that actually caught a lot of people who wouldn't have normally gone. So is that the idea of going out into the community and working there? Thank you.
I can respond to that, James, if I may. It's I think it would be very beneficial for me, perhaps in the next report, to include what our ambitions are, because in the London boroughs, that's exactly what they do. They make use of some of the community centres if it's an appropriate setting to actually carry out those physical health checks. One of our thinking is actually to put the message out first, raise the profile of these annual health checks as a whole. We've already had some support to actually say from our patient group that we actually tap into before we launch any concepts. They would really welcome the idea of not having to go to a primary care practice sometimes, if appropriate. And if they could do it in a community setting with a cup of tea, speak to people who understand them, and maybe get a goodie bag in the end of it, that would actually remove some of the fears of going into primary care settings to have their checks done. But it's definitely a crawl before we walk approach that we would like to do in Norfolk and Waveney.
Yeah, could I just very quickly come back?
Yep.
And I'm now going to share something with you of a personal experience. At home, I have a letter from my practice inviting me for a health check. I haven't taken it up as yet, which is a bad thing for obviously their rating and whether they reaching out. Basically, because I think that primary care, I've got so many struggles and challenges that actually, yes, I do want a health check, but actually, is that best use of their time at this moment in time? So bringing out in the community must be the answer. So I hope you didn't mind sharing my personal situation with that. Thank you.
Thanks, James, and thanks, Julian. Mel.
Yeah, could I just ask, I think there's a little bit of confusion around some terminology, and I think it's really important that this committee is explicitly clear on who they mean by primary care and what they mean by health check. There are various types of health check, as Julian will know, and I'm sure, Julian, you will reflect this in your paper. But I think, James, I think you're talking about the NHS health check, which is actually is commissioned from the county councils. It's not a locally commissioned service, commissioned by the ICB, and it's not a national DES. So that's commissioned by the public health departments in Norfolk and Suffolk that cover our area. That is called an NHS health check, and is not under the ICB's remit. You've then got the SMI health check, which is limited in who can deliver that. It's for patients that are on a specific register, and some are undertaken by the secondary care provider in an area and some by general practice, rather than the wider primary care disciplines. And for example, NHS health checks are also delivered by pharmacies as well. So we need to be really clear who we're talking about in terms of the provider and what type of health check we're talking about. So LD health checks is a national DES, so can only be delivered by general practice. So I think we just need to be a bit clearer when we're talking within this meeting, particularly as it's a public meeting, and be a bit more explicit about who, when, how, and not confuse terminology, because I think if we're not clear, I don't know how the general public is supposed to be clear. And I will just give a word of warning, having worked with the public health departments, and obviously in Norfolk, they've done some innovative things, working collaboratively with the LMC to get general practice on board with a change in delivery and utilising additional resources to deliver NHS health checks. I will just say that the public comments on public information can be quite derogatory and can be quite difficult, and that is going to really need managing by the ICB if you're looking at going out to the public to promote something. It's how you're going to deal with negative commentary on that from the general public, and I'd be really happy to work with you, Julian, on that, because I think there's some really key lessons that have been learned already by working with Norfolk Public Health. Thank you.
Thanks, Mel. Thanks for your offer working with Julian and co. Bill.
Yes, I just wanted to pick up on Mel's point there, because I've been pushing Public Health as the Cabinet member to spend more on the NHS Health Check and to look at the performance, which, you know, and a lot of them were delivered by general practice, but not enough. So one of the things that we looked at was bringing in alternative outside providers to help increase the provision of the NHS Health Check outside of general practice. But you know, and that has obviously meant a negotiation on that. But I don't think the public, you know, are confused when we talk about health checks. I think they are quite clear about it. I think that we ought to just be slightly careful about overcomplicating a principle about how we embed the idea of health checks in the system that we're trying to deliver in primary care. And agree the principle, and that it is an important part of what we want to offer as primary care. And that's really what I'm really keen to hear what Julian is saying, rather than an add-on to be done if you've got time when the system is got pressure, you know, to fit it in amongst all the other pressures. You know, I would like to see it more embedded as a key delivery of primary care, and you know, that's very much what I'm hoping that we will do through this committee in terms of the strategy that Julian and Shepherd have been working on, and I don't want us to think that it's just going to be too difficult or complicated to deliver. I think it's an important ambition for this committee.
Thanks, Bill. Andrew.
Yeah, I just wanted to let you all know really that Healthwatch Norfolk are in the middle at the moment of carrying out some surveys commissioned by the County Council for the NHS health checks. So we should be able to be in a position, I'm not sure when that's going to be published, but at some point in the fairly near future, we'll be able to give you some public opinion on that one. And just to say from the things I heard from that, one of the most important things is a definition of what the public should expect from a health check. And speaking personally, I think that phrase is vastly overused and misunderstood, because if you look at what's actually done, it's pretty much a cardiovascular risk check. And the public view of a health check is much wider. And unfortunately, people are seduced by these adverts you see in the Sunday papers about getting health screens and things, which of course have no evidence base at all for good outcomes. So I just encourage everybody to look at the outcomes, not the process, as always, of these health checks, and to be very clear with the public what exactly it is we intend to provide as these things get developed. And of course, make sure they're evidence-based. Naturally.
Thanks, Andrew. Any other questions or comments for Julian? No, many thanks, and I think Julian, you will picked up the framing of the discussion. So I think there's quite a few things also around health checks more widely that can be incorporated in a future note. So I'll leave that to you and the team to ponder about. Many thanks for the update. That takes us to item 9. I see Jade Robertson has joined us. This is, if if I'm correct, there was a further updated version of this note circulated to attendees. So that was in a Word document. I hope people have that to hand. And Jade, I invite you to guide us through the main points. You can assume the paper has been read, but grateful if you can pick out the highlights, and we'll open up for discussion. Thanks.
Yes, certainly. Thank you very much. So just really just to go through, so when we're talking, the paper is obviously the primary care workforce. Under the contract that we have within the ICB, effectively, it is looking at general practice within this financial year, but it is anticipated from April, we will be looking at the wider remits of primary care. So just for the purpose of today, it is focusing on general practice because that's what we're currently contracted to do under the remit of the contract that we have within the ICB. So I just wanted to really obviously go through, there has been some changes within the infrastructure. I'm one of those changes as a head of primary care workforce. So it's looking at providing additional resilience within the workforce supply to help obviously provide the contractual requirements that we need to deliver, but also help support the strategic direction of what we're trying to achieve within primary care, i.e. general practice for this first setting. Some of the other formal changes that we've had to make is the actual governance process. So previously there was a previous committee that was looking at the spending plan, all the proposals, and that was where it was formally reported. Under the requirements, we are now formally reporting into PCC. As part of our delegated authority, that's where the budget lines hold under the delegated primary care budget. So that's where our formal reporting is now going through. So hence why you've got me here today. The other elements I just wanted to talk through really was more about the scrutiny and the oversight. So again, with those reporting lines haven't changed. So we have regular meetings with NHS England and Health Education England. I've actually got one tomorrow, going through all the programs that we've got in terms of workforce retention, our training and our CPD requirements. I'm pleased to say that we are all on track for all of those retention schemes and the workforce requirements. We are looking at a review over the next 3 months. I am now looking at the review of each of those retention packages to see if they're fit for purpose. Are they delivering what is needed for the workforce within general practice, but also introducing some new initiatives and schemes. And two of those things I wanted to highlight is the GP partnership incentive model, and as well as the looking at international recruitment for our nursing staff, really particularly to help support our strategic objectives. I just also wanted to highlight the data behind it. So I am very much looking at our workforce supply and what we've got. So I've got it on a practice level basis, as well as a PCN operating model. And just to give you some really quick highlights in terms of our workforce position, for looking at a comparison from last year to this year of where we are, our nursing staff has increased by over 2.6%. Our direct patient care has increased by 7.3%, and our admin staff, clinical, non-clinical staff has increased by 20. So the deficit at this stage is looking at our GP staff. It has had a decline of 0.4%, and with the retention schemes that we're looking at to help support and boost our GP workforce. So all the plans that we've got in place are meeting the needs of our workforce supply, and we are actually seeing some significant impact as a result. The other element we really want to focus on is our new supply coming through. So this is our training and our placement capacity. This is a big, very big strategic objective within our workforce strategy to ensure that we've got our future pipeline coming through. So again, we're looking at, as part of the program, is to increase the number of educators within general practice, to increase the number of clinical placements across each practice, across Norfolk and Waveney, so that we can continue on with that workforce supply, keep them within the area, train them up and retain them with schemes and incentives. Additional roles reimbursement scheme is proving successful for Norfolk and Waveney. Already we're at 87%. With all of the budget being used, 462 whole-time equivalents are now in place across general practice, working at a PCN level and also supporting practices individually as well. So that's really a quick overview of all the key points I wanted to highlight today, and I'm really happy to answer any further questions.
Many thanks, Jade. Any questions or comments from anyone? Mel.
Yeah, Jade, as you're aware, my colleague Naomi, who leads on this area, has sent in a number of comments on this report and the paper that's in part 2. But could you please clarify the situation with the R's funding? Because it does seem to be contradictory between this paper and the next paper.
So the R's funding, that is the further paper going in a different section. So effectively, we've got the additional roles budget utilisation currently sitting at 87% being utilised across the PCNs. So that's our current position as of the end of November. We're continually working with the PCNs to look at what their succession plannings and their recruitment plans are, particularly a lot of new interventions with the LPC. We're looking at rotational roles. We're looking at joint roles with the introduction of some pharmacy work in particular. So there are a number of things that we are working with PCNs directly about so that we can utilise the full budget within this financial year.
Yeah, so because your paper says there's no underspend, the paper in item 10, the next item says there's a significant underspend. So which is it?
Currently within what we're trying to understand from each PCN is their future. At the moment, it's the PCNs are coming back to us about the utilisation. It is showing that we don't have currently, as some of the PCNs are reporting an underspend. We're trying to understand that full picture as a result. So currently, based on the succession planning, we're working within the financial budget that we've got.
Yeah, maybe
I'm still
when we
confused.
come to the finance report, Mel, we can try and see if James Granger can help shed light on the financial outlook, but we'll cover that a bit later in the agenda, if that's okay. Bill.
Thank you. I'm really pleased to see you here, and I think this is great that it's now coming to this committee. So fantastic. I applaud the change of governance. How does it fit with the ICB workforce strategy? So how different is the primary care strategy to the general? And because obviously there's a social care workforce strategy within the ICS as well. And I just wondered how joined up it was across the different parts of health and social care.
Thanks, Bill. So myself and my team sit under the ICB workforce team. So we very much are now, we were previously sitting under primary care, but we have now moved in a different directorate under the workforce. So we are all aligned under the same. So very much working under Emma at JCO as our Director of People. So our strategy works very much in similarity to the ICB strategy. So we're trying to harness and mirror some of the opportunities that can be delivered within primary care. And one of those examples is the international recruitment drive that's been working very much in an ICS level. We're now providing that opportunity for general practice. So there is a lot of synergy with the work that we're doing, Bill, and as said, we work very closely as I'm part of that directorate.
Fabulous. I mean, I've just signed off something of some jobs fairs for health and social care for Norfolk. So we're all intricately part of that.
Absolutely, we're part and parcel of that wider workforce recruitment drive. And a really good example of that is our pharmacy supply coming through. We're doing a big recruitment drive as an ICS from all different partners, and primary care will be part of that. General practice will be part of that drive as well.
Smashing. Thanks very much, Jade.
No problem.
Thanks, Bill. Thanks, Jade. Any other questions or comments? No. Many thanks, Jade. I would echo what Bill said. It's great to see the paper coming here and sort of indication of the different governance. Great to see it feature here. So many thanks for that. That takes us to the next item, 10, an update on the primary care network direct enhanced service. I believe Sarah Harvey is on the line. So Sarah, great if you can introduce the paper, and then we'll ask for comments and questions.
Thank you. Hello, everyone. Thank you for having me. So I'll take the paper as read, and I'll just give some brief updates. So the main areas I was going to focus on were around the PCN transformation funding and the bids that have been received. So as previously updated, the National PCN Development Fund ceased in 2021, apologies. But this year, the ICB has ring-fenced some non-recurrent funding to support PCN development, and we named this PCN Transformation Fund. To date, 13 of the PCNs have had successful bids, and that's been confirmed to them in writing, which has been well received. For the PCNs whose bids have not yet been received, we're working with them and their locality teams to make sure that they can access their share of the fund, and we're expecting revised bids to be received shortly so that we can hopefully approve those, and then they can access their share of the funding, as I just said. The second part of the update I was going to focus on was around the system resilience and the quality support and sustainability payment that was communicated to practices at the end of December. And this is in response to the ongoing critical incident and part of our supporting general practice throughout winter in terms of income protection. This has been well received by PCN and localities, practices and localities, and we're expecting bids. Not bids, apologies. We're expecting plans back from practices by the 20th of January. We'll be able to update further after that. And I just want to clarify and apologise for any confusion around the previous paper and around the R's budget. I have written something that perhaps sounds quite slightly contradictory. The data that was received at the end of November was that there was a forecast underspend, but there were plans to ensure that all the funding was used by the end of the year. So apologies for any confusion around that in the previous paper. That was everything I was going to update on. If anybody has any questions, I'm happy to take them.
Many thanks, Sarah, and good to hear the income protection was well received in the PCNs. Any questions or comments? No. Clear paper, clear update. Many thanks, Sarah. Looking forward to a next update soon.
Thank you.
Takes us to item 11. I think, Shepard, you will talk to a specific CQC report.
Thank you. Hi. Okay, so this is our usual practice to bring members up to date with the CQC activity in our system. Wensum Valley has been reported for a while through part 2, and this ICB has been supporting this practice for some time now. I'm really pleased that we've made some progress, and we will continue to make more progress with this practice, as you will be aware that this practice was rated as inadequate back in November. But it has now since been re-inspected, and they've made some progress and now requires improvement, which is really positive. Just to highlight the areas that we have improved, I think we've improved across. We've strengthened the delivery and the care that is being provided. So in terms of the caring, that is good now. And also the responsiveness is also good, which is positive. And I think it attests to some of the challenges that we are facing as a system in terms of access to services. So it's good to see that the practice is able to respond. We still have areas that we need to continue to work on, obviously around the delivery, effective delivery of services, and around leadership, as well as the safe domain. Just to highlight some of the areas that we'll continue to work on is around the prescribing of medication, which seems to be a theme across a number of practices. It's about variation. It's a national drive to improve our prescribing practice. Leadership continues. There are some improvements, and I think the action plan we have has drilled through in terms of roles and responsibilities for partners and practice management. So that continues to improve. Again, the structures, the governance is strengthening. Recruitment is also strengthening. So really pleased about the progress so far made, but more positive about the progress that we need to continue to make working with the practice. More discussions will take place in part 2, but for now, I hope this provides members with the information that they need to work with now. Thank you.
Thank you, Shepard. Any questions or comments? Chris?
Yeah, just to add, thanks for that, Shepard. So our newly appointed patient safety nurse fellow has linked in with Wensum as well, just to support around some of the governance around incident reporting. So they've made lots of progress ahead of this, but sort of continuing to work with them to help embed some of that work that they've achieved. So I think that's really positive, and they're really on board. So that's a positive step forward, just to highlight.
Thanks, Chris. James.
Yes, thank you very much. I'd just like to note, if I've got it correctly, the speed in which that you've been able to give assistance and to move the rating. It looks within 2 or 3 months that is achieved, if I've read the report correctly. If that is correct, congratulations.
Thank you. And just to say, the work has been going on over a long time now, but it's been accelerated recently, and working quite closely with CQC. And I have to say, CQC have been amazing in supporting the practice too.
That's really good to hear. Thank you.
Thanks. Any other questions or comments? No, many thanks, Shepard, for the update. That takes us to item 12, terms of reference review. And I think, Amanda, you've joined. You're going to guide us through that.
Yes, thank you, Hein. If I could go through the terms of reference with the committee, and Fiona is going to talk about the scheme of delegation. The terms of reference for the committee have been updated to reflect the change that is about to happen in terms of the transition of primary care services, and the ask really was to make sure that the committee is able to review the information that it needs to, and that we've got a manageable way of ensuring that decisions are taken at the appropriate level. So I believe a track changes version of the terms of reference have been shared, or is it a clean copy? I can go through each of the details. If I can take the paper as read, you'll see that initially there is an explanation under section 2 about the authority of the committee and the various areas that it's going to be covering. There's also reference to a scheme of delegation, and that is the ICB's document that is set out in the governance handbook. It's a document that manages at a high level delegation and where delegated decisions are made. The majority of the document hasn't been amended, but you'll see that there's been some updates to attendees to expand the membership of the committee to cover the various representative groups, and the remaining updates really are around the responsibilities of the committee, and the wording for that has been taken from the delegation agreement itself, so that we are ensuring that we're covering the areas that are being delegated to us in the terms of reference. I don't think there really is anything of any material change that has been changed in the terms of reference. One of the things that I did want to highlight was that we have had feedback from each of the 4 representative areas. The majority of all those requests and comments have been looked at and are being accepted. They do not materially change the terms of reference. There is one request about making the committee a private committee and not a public committee. However, that's not something that would be possible. Because the committee is made up entirely of ICB board members, there is legislation that requires us to meet in public. It's also set out in the ICB's constitution that such a committee has to have a public meeting. So we do need to continue with a public meeting. There is also another change in terms of the number of days that the papers are sent out. And currently it says at least 5 calendar days in the draft, but we're going to change that to at least 7 calendar days. And that's another change. So I think those cover the majority of the changes within the document, but very happy to take any questions or queries about any other information or changes in the terms of reference.
Thanks, Amanda. I mean, one substantive change is the creation of the delivery groups, which are captured in there. You want to say a bit more about that before I open up?
Yeah, so the delivery groups have been set up to address some of the work of the primary care, medical services and dental services. And this is really to manage the operational side of some of the work that will be transferring to us. I believe that it represents a lot of the work that will be dealt there will represent the similar structure that has been created by NHS England. And it is to ensure that the primary care committee does not get bogged down with too much of the general day-to-day managers' work that needs to be transacted, so that there is more time for this committee to concentrate on the more strategic and higher level decision making.
Yeah, thank you. Let's see a few hands up. Mel.
Yeah, I'd just like to make our comments public, which we have given quite a lot of comment and asked some questions. These have only been shared so far with Fiona, Sadie and Amanda, and we are still awaiting some responses to a number of comments. However, we have real concerns how such a government document can be proposed to PCCC for approval within the Part 1 agenda when this isn't the final version. We don't feel that attendees or voting members are going to be commenting on the final version. We haven't seen an amended version, even though we've been told certain things that we've put through will be accepted. So it feels that this isn't good governance to be voting on something when you're not actually seeing the final version. And seems rather a dangerous precedent to us and isn't something that the LMC can support.
Yeah, I don't know the details, but Amanda, maybe you closer to this.
Yeah, so I appreciate the LMC's comments that they haven't seen the final version that actually shows that we've accepted their comments, and so the wording won't have been something that they will have seen. But that is something that we are going to make sure that we have accepted those comments, except the ones I think that I've mentioned around the meetings in public. So I appreciate that that Mel has got concerns around not having seen the final version. I think what we can do is just reiterate that we have accepted those, and they will be shared. A draft will be shared after this meeting.
Yeah, I think my concern is more that the voting members haven't seen the version that they're voting on, because this is on the agenda for approval, not for noting.
Yeah, it's not for approval because the ICB board is the party that will approve, but I take the point that support is being sought of the
Well, on the agenda
members.
it says it's for approval. It says in the paper it's for approval. So I think if it's not for approval, we need to be changing some wording.
Yeah, well, I saw Sadie put her hand up, so maybe Sadie can clarify. Want to come in, Sadie?
Yeah, thank you. I think what we're trying to do is to make sure that the final version that leaves Primary Care Committee is one that is being recommended to the ICB board. And due to timings, the ICB board is going to be reviewing and hopefully approving these terms of reference at its February meeting. So to leave this until the February Primary Care Committee provided us with a little bit of a challenge in terms of turning papers around. So what I'd like to perhaps suggest as a result of the feedback that we've heard today and what Amanda's said is that we take on board any comments from members and attendees today, combine them with the feedback that we've had from all the local representative committees, make sure that we've responded to all of those comments and which ones we can accept and which ones we can't and why, and then circulate an updated version virtually outside the meeting, which members can then support or otherwise the recommendation to the ICB board. And I think we do have time to do that virtually, and we can bring back that copy for noting at the next meeting in public. But what we couldn't do is kind of wait for all of that to happen and then bring it to February for final approval, simply because of the time frames.
Yeah, I think that's a very pragmatic approach. I think it's also good that James, as the chair, can sort of give his nod to that updated version. So I like that idea. Thanks, Mel. Thanks, Sadie. Rosemary.
Yes, just thanks, Amanda, for that. I couldn't find anywhere in there, and I don't know whether it should be included, the length of term for members.
It isn't something that's usually that we've got set out in our terms of reference. It's something that's held otherwise for our non-employed board members. So it's not something that we stand as a standard would include in terms of reference. But I think it is a good point that we should have something that perhaps we put in another document.
I was just sort of thinking, you know, for sort of just clarity and sort of transparency, just so it's kind of clear to everybody, you know, both the members involved, but, you know, the wider audience as well. Just, I think, just to have it clear somewhere.
Yes, I don't think terms of reference would perhaps be the right place, but I think that is a valid point, that it should be somewhere that we can point to. So one of the things that I am doing is updating the governance handbook in the next few weeks. I think that would be an appropriate place to have that sort of information. It is in the Constitution as well, but it doesn't actually, it just gives a general term, how long somebody would be appointed. It doesn't give start and finish dates. So perhaps, I think maybe your comments around start and finish dates, so it's clear when the next terms are due to end.
Lovely, thanks, Amanda. Thank you.
Bill.
Thank you. I welcome this. I mean, and I think it will change the role of the committee, I think, slightly, because we will need to be more strategic and more assurance driven than perhaps we have been in the past, especially as we're going to have these delivery groups underneath us with primary care and dentistry. I am concerned that because let's be frank, it's a public meeting. Dentistry is not in a happy place, in my opinion, and to pass it to us and then expect us to performance manage it, be held accountable for the performance of dentistry. I would be very keen that we should have a very clear idea of the current performance of dentistry and its trajectory over the last years, so that we can start from a place of a realistic achievement and not be suddenly held accountable for a perfect service when we are inheriting one that is less than perfect. And I think that it would be wise for us as a committee to look at that and have that discussion right at the beginning, so that we don't get caught up in trying to do an impossible job. Because I'm very well aware there's an immense amount of goodwill and people working extremely hard out there who want to deliver a really good service, and I think we need to be able to help them to do that. And I think in order to do that, we need to have a clear overview of the history of what we're inheriting. And I don't know so much about the other services because I don't know so much about them, and my how I'm going to put my telephone hasn't rung so much about the other services it has about dentistry. But I think it would probably be sensible for us to do that across. I mean, I think in terms of the job that we're being asked to do today, it is, do we as a committee have any particular issues with the documents as provided? And if we do, to flag them up, but if not, then they can go forward, hopefully with broad assent, subject to any final issues that have been articulated by Amanda. I mean, I sit on the ICB, as does Hein, as does our chairman, James. So I think that if there are things that the committee feel that we should raise at that meeting, I'd be very happy to do that in order to bring it forward. But I do believe that if we are broadly in favour of the what's proposed in terms of the two delivery committees underneath this committee and our enhanced role on the other, taking on board the responsibilities as proposed, then I think we should say so. Thanks very much, Hein. And I am.
Thanks. Yeah, and maybe I speak before my term, but I am as well, and I was able to convey that in an email exchange with Sadie and Fiona and Amanda earlier. I like the addition of the delivery groups, and as you said, Bill, I'm looking forward to a bit more strategic shift for the PCCC and an assurance that affords this change. Andrew.
Yeah, hello, Amanda. Just wanted to clarify the membership of the delivery groups, in that I spotted that Healthwatch has a question mark by it on both of them. Just to say that the vast majority of the comments we get from the public are both general practice, but also hugely about dental problems, as we've already discussed numerous times. Could you clarify that we're welcome to attend, or is that still in discussion?
If I could defer to Fiona, who has more information on that.
Fiona.
And yes, Andrew, we absolutely welcome Healthwatch input. The reason why there's question marks there is not because we don't want Healthwatch, it's because we're very conscious that by creating two more committees or groups, that we're asking people to do an awful lot of work, but obviously we will try to manage the workload. But some of the question marks are there because we obviously want to come and have that conversation with yourselves. So absolutely, patient representation on those groups is absolutely essential. Yes, look forward to working with you. Thank you.
Okay, great, thanks.
Thanks, Andrew. Thanks, Fiona. Mel.
Yeah, I just wanted to come back in and just clarify to those who haven't seen our comments that the concerns of the LMC don't relate to the formation of the delivery groups. As our queries are much more in the minutiae and terminology and wording. So I think if the ask of voting members today was to support the progression and formation of the delivery groups and the proposed structure of what goes where, then I think, you know, that's very different to actually approving the actual wording of the actual document itself. And I would just like to say that we completely understand Bill's comments as he's portrayed them, and can see that that's a consideration for committee. And again, would absolutely support Andrew's comments that, you know, if Health Watch have the capacity, then they should definitely be on those delivery groups as well.
Thanks, Mel. I had one further detailed comment which I have shared with Fiona and Amanda, that the PCCC should be the final approver of practice mergers should they be put forward. So that's by way of completeness. So I do hear strong and broad support, but as Sadie suggested, a sort of final version will be circulated to voting members for a virtual sign-off well ahead in time before board discussion. Many thanks for input. Many thanks, Amanda and Fiona, for support to this agenda item. I want to move to the next item, which is the prescribing report. And Michael, I think you will start it first.
Yeah, thanks, Hein. Yeah, we've got 2 agenda items for the price of one. A bargain. Okay, I'll be very brief on the prescribing report because I'm conscious you'll have some questions about the pharmacy strategy paper, which is Tony Dean from the LPC has very kindly attended to field questions, comments on that. My colleague Jessica, who is going to attend, is not well at the moment, so so I'll be brief on this. Okay, so the usual bar chart on page 2 just shows you a snapshot of regional benchmarking on cost per STRO-PU. We'd normally be third on this one, but in October data, we spent £1.4 million on flu vaccines, which is in that raw data there, which is all charged out. And we spotted some very large coding errors, which we're working through as well. So next month, we should be back to 3rd position, which is based on our deprivation, as I showed a couple of months previously, is probably where we ought to be based on that that identified issue. Table 1, just to show you the prevailing wind in which we're trying to come in on budget in terms of cost pressures. There's the no cheaper stock obtainable, so price concessions and price increases. So year to date, that's just 4 million. And we thought that last month the peak had gone down, but if you look at table 2, the peak has actually started to increase again, or it is peaking in terms of cost pressures in price concessions due to drug shortages, etc. Some of it which is driven by antibiotic shortages. Yeah, so November nearly £1 million, and in December there's a 1 missing there. It's actually £1.2 million projected cost pressure on the system there. The dependence forming medicines, slight improvement in opiates, gabapentinoid staying the same. We're hovering around 3rd and 4th position nationally on hypnotics and anxiolytics, but we are decreasing faster than national, as you'll see on table 5 there, as usual. I've gone very light on antibiotic performance because something has driven up prescribing of antibiotics recently, and we're just working through how we're going to reflect that nationally and within the PQS. And I've already had a conversation with Naomi in the LMC about how we can, as we've got it in the PQS as a target, how we're going to mitigate and judge performance on that. So it's a slightly complicated issues, but antibiotics has certainly seen a big increase for explainable reasons and price increases. So I'll move on because the community pharmacy strategy, so this is the East of England Partnership Strategy for Community Pharmacy, which my colleague Jessica and Tony have been involved in at a regional level in developing. It's a good summary on page 3. It's quite an ambitious direction of travel. and there are, significant issues with pharmacy workforce, as you'll know, locally, particularly, but also nationally, that Tony can perhaps allude to. But we do need to think about where this needs to go next, and which perhaps of the delivery groups, or if we need a separate delivery group for community pharmacy strategy. That's something perhaps comments are welcomed on. But I'll hand over to Tony. I don't know if you wanted to do any slight introduction and just ask for comments, questions on this. As I say, it sets out the ambition for community pharmacy, which is fantastic in its ambition. Tony.
Good afternoon, Tony. Welcome. Indeed, it would be helpful if you can provide some introductory comments to an excellent paper.
Yeah, thank you. I mean, obviously, this has been co-produced over a period of this last sort of 6 to 8 months, and it is an ambitious paper. It's part vision, it's part strategy, with some sort of reference to some plans, some actions that we may want to take. Community pharmacy is in a difficult place. I'm not sure I'd use the word happy place about community pharmacy either at the moment. Over the last 6 years or so, we've suffered 30% funding cuts to our national funding, and have been incredibly badly affected by the additional roles scheme. Approximately 60 or 70 pharmacists are now working, in additional roles, and that's most welcome. It's great for the system, but it must be admitted that the majority of those have come from community pharmacy in a quite a closed workforce. That is a considerable hit. So going forward, it's why we're so keen to work with workforce to make sure that we do grow more of our own pharmacists and keep more of our own pharmacists in the area. And fundamental to this will still be that we will still work under a national contractual framework. And if that national contractual framework isn't right in terms of the funding and the enablers, then it's going to be very challenging to meet this vision and these objectives. But like it or not, from the 1st of April, the ICB is responsible and accountable for community pharmacy services, and indeed our services are increasingly reliant funding-wise on integration of services, on service delivery rather than simple dispensing. And if we can't integrate services in Norfolk and Waveney as well as other areas, then our contractors will have a disproportionate disadvantage in being able to access national funding. So there are challenges, but we need to work together to try and work our way through those. I would agree with Michael. One of the concerns I raised with Fiona was, just appointing an 8C and having an 8A in place to look at community pharmacy integration won't be enough, but actually was reassured that actually development integration is a completely sort of separate work stream to this, so there will need to be considerable resources and efforts put in. I think initially just a lack of awareness of community pharmacy services is going to be a significant barrier that we need to overcome. But I'm keen to work with the system on where community pharmacy touches and how we sit within the system as we develop. We are the 3rd largest group of healthcare professionals. We do see patients more often than anybody else. So the potential, given the challenges, is there for us to take far more pressure off other parts of the system if we can get over some of those enablers, but it will be a challenge. Probably waffled enough there, over to questions.
Thanks, Tony. The document at least served to bridge some of the knowledge and awareness gap that I had myself, so it's very welcome and clearly laid out. And let's open up for questions or comments people may have. I'm surprised. Oh, there's one. Sadie.
I think it's really clear that the plan on a page, or the strategy on a page, I should say, on page 3 is really clear. And I don't think anybody could argue with anything that's set out in there. I know that this was developed regionally. And as Michael has said, Jessica has worked really hard with you as well to make sure that the Norfolk and Waveney influence is within the document. I guess as we think past April, we will need to think about how we sort of put the infrastructure around delivery on this. We have our commissioning being hosted by another ICB for us in terms of the contracting side, but we're still going to be responsible for strategy and development locally. I'd just like to say to members that we are working on our primary and community development approach, and the intention is to set up a board which will look at this, which will include the LPCs as members of that, and I think this probably needs to be one of our early agenda items, so that we could think about how we put our plans around this in terms of delivery against the strategy, how we link into the workforce team, and so on.
Thanks, Sadie. Many thanks for that. Any other questions or comments? Maybe you see a reflection, Tony, of everybody trying to get their head around what is going to join per April. So
yeah, I understand that. And I mean, one thing I really welcome is that it's recognised that community pharmacy could and should sit squarely within primary care, with lots of dotted lines to other places, because we touch community care, we touch medicines optimisation, we touch many other places. But fundamentally, if we're going to be properly integrated, it must be from within primary care itself. Sorry, yeah. Mark, I didn't mean to interrupt you.
I saw lots of nods when you said those words, Tony. Mark, you want to come in?
Yeah, and actually that was pretty much what I was going to say, Tony. I think it is such an integral part, and you know, our days at the moment are consumed with urgent care pressures, and that's including primary care, including hospitals, including ambulance service, right across the board, and I think absolutely community pharmacy as well. And we know what a vital role that it plays. So I know we've worked on schemes together in the past, Tony, you know, on a smaller scale, haven't we, that have had a positive impact on systems. So I think by bringing this closer together, integrating services, I think there's some, the optimist in me says there's some real opportunities here as well in this change. So look forward to working with you, Tony. Thanks.
Yeah. Thank you, Mark. And just for the group's information before I sign off, yeah, I mean, in the northeast of England, they have just introduced a regionally commissioned Pharmacy First scheme. So I walk into your pharmacy and get funded consultations, because it wasn't happening nationally. So, you know, there are innovations that could be done to take pressure off GP practices, and I think we possibly need to be quite ambitious. Just because all pharmacies are not in a great place at the moment doesn't mean to say that there are quite a number that are in a place to do more. So I think we need to be, you know, quite urgently innovative and ambitious about what we could do, but realistic at the same time.
Thanks, James.
Last hurrah, really. There would be also some mileage, I think, in a sort of homely medicines pre-authorization scheme. You know, there's sort of some of the low-level stuff that clogs up GP surgeries that we know pharmacists could safely deliver and could be trusted to deliver without a prescription. You know, that kind of thing. And I think I was in Worcester where that scheme worked well. That supports pharmacy, reduces the pressure on the system, but is often, particularly with sort of anxious people looking for Calpol, for example, when it comes to paediatrics, that kind of thing, it would be good to explore that in future years.
That's exactly what's just been introduced across the northeast of England, James. You know, obviously we've historically wanted to not anybody prescribe those things for low acuity conditions, but if that's still blocking GP practice up, then perhaps we need a rethink. But this isn't the group to discuss that. But no. I have got the specs and the SLAs for all of these services for discussion.
But I think it is useful just to say your resources, you know, you and I have talked about this lots and lots, haven't we? So we know that there's a squeeze. So some sensible decisions that are cost effective could reduce demand and free up elsewhere. So look forward to hearing more.
Thanks, Michael.
Yep, I'm off mute. We are looking at the kind of OTC provision, particularly for asylum seekers. We're looking at that at the moment. I'd be interested to explore the model from, I think you said, the northeast there. But as you said, James, it can be, you know, people who need it most aren't the people who access it. It's the people who sort of perhaps want it more than those who need it. But so that be very interested to look at models where it's working well. We're also looking at moving out oral antivirals into key pharmacies rather than the hospital sending them out at the moment, just so you're aware, and that should be going live fairly soon, etc. But yeah, I look forward to working on this via the various fora that we report to. Thanks, Tony.
Good. There's no further comments. Many thanks, Tony and Michael, for respective updates, and much more to follow on community pharmacy and integration. So look forward to seeing you on future occasions, Tony. That takes us to item 14, the finance report. The end of the year is coming in sight, James, so hopefully also the clarity where we're going to end up.
Thanks, Hein. Yeah, as usual, I'll take the report as read, but highlight the key points in there to you all. So beginning with the exec summary page, so this report's produced in arrears due to the timing of month end. So it's reporting the 5th month of the ICB accounts, which is month 8 of the financial year, and has a forecast of 9 months in there for the ICB. You can see from that exec summary that the position at month 8 for primary care and prescribing budgets are £1.6 million adverse to budget. However, this needs to note that there's also a £3.5 million payment due from NHS England for the additional R's spending to be received in full, which we believe will occur around month 10. And then the underlying position, once this is taken into account, will be £1.9 million favourable to budget. Also to note, the position includes an efficiency target of just over £7.3 million built into that budget, and that forms part of the full year efficiency requirement of £8.4 million. Through the continued monitoring of those efficiency projects, we are now forecasting them to deliver slightly below plan. The project with the highest potential on span at the moment being the low risk, cost effective switching project. Moving on to the financial summary, this shows that GP prescribing is 0.6 million adverse to plan at month 8, with the figures being 2 months in arrears. This is showing that from April to September, estimates cumulatively were undervalued. In addition, the efficiency savings have materialised in this period, allowing the forecast to be delivered, albeit though at the moment there is that small under delivery at the moment. Efficiency expectations are also baked into the budget of that £7.3 million requirement for the 9 months. We've received 6 months of actual achievement so far. There are also prior year benefits within GP prescribing. These are critical to the 23-24 plans, which are now beginning to develop, as these benefits are non-recurrent to 22-23 and will not be available in 23-24. There is a prior year benefit and other positive variances within delegated primary care also, which have crystallised worth just over £2 million year to date. Moving on to the detailed financial analysis, this shows the key drivers behind the prescribing spend being, however, there are still some key areas of risk around CGM and SGLT2 with a high degree of uncertainty over the financial implications of these factors. We receive additional impact figures for these areas and DOACs, and we can see the year-on-year increase in these areas are now all showing large increases up to month 8. And also worth mentioning the NCSO pressure, as Michael said in his report, that is creating some large variances and contributing towards that prescribing overspend. So that was all the areas I was going to point out. If there's any questions or queries.
Thanks, James, and thanks for talking to the few queries I asked you offline. Any questions for James? No, many thanks, James, as usual. That takes us to any other business. First, let me check in with Sarah whether any questions were received from the public.
No, fine, we haven't had anything.
Thanks. I think there's at least one member of the public in this call, so let me check. Good afternoon, Shuderi, if I pronounce it correctly. Please go ahead.
Hi, thank you. So I just really wanted to ask if there's any kind of plans of addressing domestic violence and abuse within a healthcare setting, where that kind of sits in your priorities and your plans. You may know, obviously, as we've been speaking even today, that prevention, early intervention is a priority. There's health issues that are connected to domestic violence and abuse. And with the DHI in Norfolk, I just wanted to know, what are your plans to try to kind of improve general practice in and their training around identifying domestic abuse at an earlier stage?
Thank you for your question. Just checking who is best placed to try and answer the question. Mark, thanks.
Yeah, just good afternoon and thank you for the question. I think in terms of being able to give you a full and comprehensive response, we might struggle on this call, but if we could take your details, if you could use the contact us email, and we'll be sure to get back to you. I don't know if anyone's able to update from a primary care training perspective, whether there's anything that we can add at this stage, this meeting, Sadie, but if not, hey, we will get back to you with the detail. If you could give us a few days on that, please.
That's great. Thanks so much.
Thank you.
Yeah, thanks again for your question, but I think, as Mark said, to do it proper justice, we better make sure we have a fuller answer available for you. Any other business from anyone else on the call? No. For those joining part 2, can I suggest we reconvene at 3:15? To anyone else, great seeing you again. See you on the next PCCC. Have a good rest of your day.
Thank you.